Well, good afternoon, everyone. Thanks so much for joining us. My name is Matthew Eisenberg, and I'm the director of the Center for Mental Health and Addiction Policy. We're excited to have you at today's event on innovations in opioid settlement funding. This event is actually the capstone event to a year-long series the center has held here at the Bloomberg Center for a variety of different discussions on mental health and addiction policy issues, capping off 10 years since the center was founded. So we're happy to have you here. We saved the best for last, so we're glad you're here for that. We want to thank the Provost's Office, the Bloomberg American Health Initiative, and the Bloomberg Overdose Prevention Initiative for funding. We want to thank all of our faculty leads who helped organize this, Abby, who you'll hear from momentarily, and Sabria Linton and Sacchini Bandera. And of course, none of this would be possible without Sam Rosenberg, who is the excellent coordinator for the center. So I will, without further ado, I'll pass it over to Abby. Thanks so much.
Okay, someone else is controlling this. Okay, great. Hi, everyone. I am Abby Winokur. I'm the program director for the Bloomberg Overdose Prevention Initiative. And I am so happy to be here to introduce you all to what is going to be a wonderful discussion and panel and kick it off with some background on opioid settlement funds, the Hopkins Settlement Tracking Project, and the principles to guide expenditures from opioid litigation. So without further ado, I will dive into some background. So just a very big picture history. Nationwide, states and local governments have brought litigation against companies along the opioid supply chain. That's pharmaceutical companies, distributors, and pharmacies, alleging their blame in the first wave of the opioid crisis. In 2021, the first national settlements were reached, and to date, more than $56 billion have been committed to states, local, and tribal governments over an 18-year period. These funds are controlled by several distinct entities within each state, and they've been allocated based on an attempt to quantify the scope of the public health impact within each individual state. So these funds are controlled by distinct shares within each state. Typically, this looks like a state share, a local share, and a settlement council or committee. In some cases, there is another third-party share, like an administrative subfund. On the right of the slide, you see an example from the state of New York, which just shows the breakdown of state, local, and settlement fund share. But this looks different across every state. So in order to introduce the principles for the use of funds from settlement litigation, we need to go back in time and provide a little bit of history. And so we'll think about the Tobacco Master Settlement Agreements of 1998. This was an agreement reached between 4 major U.S. tobacco companies and the majority of U.S. states for the tobacco companies' role in perpetuating smoking-related illness and addiction through their misleading and harmful practices. Companies were ordered to pay over $200 billion across 25 years. Unfortunately, hardly any of this money, estimates suggest only around 3%, ever went back to prevention, cessation, or tobacco risk reduction efforts. The rest were absorbed into general funds, and without any mechanisms in place for accountability or tracking of where that money went. Much of it, it's just unknown what it actually went or was invested in. As opioid settlement funds have begun being allocated across states and communities, we have recognized in public health that there are few mechanisms in place to prevent similar misuse. This led a series of public health leaders to think about how we could avoid these settlement funds reaching a similar fate. And that led to the development of the principles for the use of funds from the opioid litigation. This is a series of 5 principles meant to guide opioid settlement investments. They were created by members of this team at Hopkins on the Bloomberg Overdose Prevention Initiative, and at this point have been endorsed by over 60 national organizations. These principles have come to be seen as sort of the gold standard to guide settlement fund expenditures, and they're really looked at as kind of the model for how to think about allocating these funds in a way that aligns with the intention of the settlements. So what are the principles? First and foremost is spending money to save lives. This one really serves as a reminder of the real intent of these funds, which is to abate the harms of the crisis. The goal is for money to go straight to helping those most in need, reducing overdoses, and supporting those at the greatest risk of experiencing an overdose or a substance use disorder. The principles go on to encourage several other considerations to guide effective spending. This includes investing in evidence. We know there are many programs along the continuum of care which have an evidence base to support individuals with a substance use disorder. And we also know that there are many programs that are not evidence-based or that run counter to evidence, but that are receiving funding. So it's super important to ensure that funding decisions are made in alignment with evidence, or at least supported by existing research and data that shows which programs have an evidence base to be effective. We encourage focusing on prevention and the reduction of the onset of new cases of substance use disorder. Again, it's super important to do so thoughtfully and ensure that funding going towards prevention is supporting programs that are in fact aligned with evidence and not those that are shown not to work. A priority on racial equity. This is particularly important in the context of new data that we've seen in recent years showing declines in rates of overdose across the country, which of course is fantastic to see and something all of us in public health are really pleased about. But we've also simultaneously seen disparities on the rise, particularly among certain subpopulations, including people of color. And so it's more important than ever to ensure that these funds are reaching those most disproportionately impacted by the crisis, not just those that are easiest to target and find. And then finally, a focus on transparency. The public has a stake in how this funding is used, and it's impossible to assess the quality or the impact of expenditures without a clear record of how the money is being spent. And this applies as well to processes. So we encourage transparency not only in where money is going, but also in how spending decisions are being made to ensure fair and transparent processes. So these principles were introduced and what very well received. My clicker is not progressing me. Is there another way to move forward? Thank you. But as my predecessor in this role and others went about sort of introducing the principles and their scope, they received the question from a lot of audiences, well, it's great to have these guiding principles in place, but where's the money actually going? So that led to the creation of the Opioid Settlement Fund Tracking Project. That is a partnership between Aneri Patani, whom you will hear from shortly at KFF Health News, Kristen Pendergrass of Shatterproof, who I believe is potentially here online, and my predecessor in this role at Hopkins, Sarah Whaley. The goal of this project is to identify all publicly available expenditure data across all shares, that is the state, local, council or committee, and additional sub-shares, compile that data into one comprehensive database, which includes DC and all 50 states, and characterize each individual expenditure by a coding scheme to make sense of where the money is actually going. This includes a series of buckets, core strategies, and then, when relevant, special interest tags. So you can imagine this is a major endeavor, that it is, but what have we learned so far? So Project Year 1, which you'll see in the middle column, encompasses calendar years 2022 and 2023. This was done because the project began in 2024 when 2 years of settlement expenditures had already begun flowing and been allocated. Project Year 2 spans calendar year 2024, and we are now in the process of collecting data for a third calendar year, that's 2025. Some basic takeaways at a kind of high level. You can see that the largest bulk of funds in both project years have gone towards treatment, then harm reduction and recovery services. We see a much lower proportion going to prevention, I just want to caution that it's important to note that it's difficult to draw direct comparisons between these 2 years of data because there were some methodological changes between the 2 years of data collection, and the combination of spending across 2 calendar years for the first project year makes it difficult to draw direct comparisons. Excuse me. As far as our core strategies, and a note that these are not mutually exclusive, so something tagged in a bucket will also be tagged as a core strategy. We see the largest proportion in both years, again, going towards treatment, recovery services, and then naloxone medications, with prevention reaching 8 to 9 or 10-ish%. So we are currently, as I mentioned, underway with the 3rd year of data collection. We hope that with the passage of time, we'll be able to start doing some really interesting research to look at trends in spending across multiple years. We have some of our research assistants in the room today and online, and we are very grateful. It is, as I said, no small feat to identify what in the first project year was over 7,000 individual expenditures, and in the second year, over 10,500. So where are we going from here? Those of us on this team and who are working in the settlement fund, research, and policy spaces are thinking about some key issues as nearly 15 years remain in settlement fund expenditures. First is to ensure, as I mentioned, racial equity, and that these funds are actually reaching those populations at greatest need and who are facing the greatest risk of either substance use disorder or overdose. That includes a focus on racial equity and identifying those populations that are really facing the greatest burden of this crisis. Improving transparency and reporting consistency, not only to make our jobs easier when we're tracking expenditures, but also to improve the public's ability to understand where this money is going and make sense of these trends in spending. Avoiding misuse and supplantation or replacing an existing funding stream with settlement funds, particularly in the context of the federal funding cuts that we've been seeing and the very uncertain federal policy environment. We'll hear a little bit about that at the end of this conversation. Certainly questions of monitoring and evaluation. We're thinking a lot about how to monitor and measure the impact of this spending. Are these dollars really going towards saving lives in communities? Assessing the actual quality of the investment across buckets. For example, if a community tells us that something is prevention, does that mean it's really going towards prevention? Is it that it's going to a prevention program that in fact does not have an evidence base? So there's a lot of research to be done to understand whether trends in spending are actually aligned with evidence-based strategies. And then finally, segueing us into our fantastic conversation we're about to have today, is identifying and raising examples of best practices, positive use of spending, and of course, innovations and settlement fund expenditures. So we're so thrilled to have a really excellent panel here to discuss some best practices and raise up some really interesting and unique work going on across the country with settlement fund spending. And without further ado, I will pass the microphone to Aneri to bring up our guests. Thank you so much.
Hello, everyone. Thank you all for coming here today. I'm Aneri Patani. I'm a reporter with KFF Health News, where I've been doing a series of articles for, I think this is my 4th year now, covering how state and local governments are spending their opioid settlement money, how they're making decisions around this. And so I'm very excited to have this conversation. Been talking to the folks up here about it, some of whom have been in my articles before. So I know that they'll have a lot of great stuff to share. Before I get started, I do want to let everyone know that in a few minutes there's going to be a QR code up on the slides. That is your way of sending in questions for us to ask panelists. So I'm the moderator and I get the privilege of asking my own questions first, but then I will get to yours. They'll come to my phone, and so I'll be looking at that and asking them towards the end. So at any point, whenever you want to scan that and send them in, please go ahead and do that. To get started, I'm going to ask just our panelists to quickly introduce themselves, just give you their name and title. There's a lot more detail. These are really cool, accomplished folks, so you can read their full bios online and on the papers you have at your seat, but I'll ask them to just go through and give you their name and quick description of what they do. Tracy, you want to start us? It should be on.
Tracy Gardner, I'm the Executive Director of the National Black Harm Reduction Network. Our Gen Z folks make us say NBURN. And it's a new organization, barely 3 years old, but the concept of black harm reduction is definitely not new.
Liz Auk, Countryside Public Health, which is Big Stone, Chippewa, Lacaparo, Swift, and Yellow Medicine counties. I'm in southwest Minnesota, and I am the administrator of the Public Health Agency.
Hey everybody, my name's Dalton Barrett. I work in Edgecombe County, which is eastern North Carolina, and I serve as Opioid Settlement Program Director as well as the Post-Overdose Response Team Manager.
And hi everyone, my name is Alyssa Kittless. I'm the Opioid Settlement Program Manager in Wake County, North Carolina, which is where Raleigh is located, and I'm also a proud alumni of the Bloomberg School of Public Health.
So the theme of today is innovations in spending. The folks up here could talk about lots of different innovations. In the interest of time, we've asked them each to focus on one. So I'm going to start off by asking each of them to kind of talk a little bit about one of the innovations that they've seen and they've worked on in the spending of opioid settlement funds. Tracy, can I start with you?
Okay. Fortunately, you should have in your chair a nice one-pager that we prepared about Next Distro. And in full disclosure, I am the board chair. I have been on the board since its inception. It's barely 6 years old. It basically is mail order harm reduction. And I think the innovation part of it is really about the fact that from the time it started, a woman named Jamie Favaro, who was working with the National Harm Reduction Coalition, and as the Harm Reduction Coalition has been around since shortly after our first opioid epidemic, but heroin and HIV, and so she saw the need to develop this because of the stigma that persists around drug use, around access to syringe exchange programs, and the fact that traditional public health and what I call the mental hygiene system in which substance use disorder and addiction live have been generally hostile to people who are using drugs or in some stage of their own defined recovery that is not abstinence only. This became, syringe exchange and other harm reduction strategies were developed to address the harms from HIV and other bloodborne diseases. Injection drug users were almost 60% of the HIV cases. And after a lot of tumult and controversy, we were able to demonstrate dramatically that the harm reduction strategies were key in driving down HIV transmission. So this is the pot in which the idea of Next Distro developed. And this idea that you are still going to get harassed if you're trying to buy syringes from a drugstore, if your state allows that. We're still dealing with some states who think that naloxone is illegal. Test strips are contraband, and all of the other barriers that I think we know a lot about. So this idea of mail order, for example, in Tennessee, we have 600 requests. Let me just say overall, there is a wait list of over 1,000. So in Tennessee, there are 600 requests that really signal unaddressed needs. A lot of folks who use Next Distro are folks of color. They are in rural communities, but often they're also in places where there are other SSPs and they simply don't feel comfortable or safe in going to them. So there is a distro side, which is the distribution network working with organizations across the country to facilitate the distribution of the harm reduction supplies that include naloxone test strips, and then the one-to-one work, which is really critical because these are relationships through email where we know everyone that we're dealing with and we tailor what they need based on what they tell us. And it's just an ongoing email relationship that puts their privacy and confidentiality at the height. And I'm going to just close in terms of the overview, happy to answer more questions about how it works. But in some places, we're working with state health officials in getting the supplies to community organizations and individuals. But a lot of the interaction that Next Distro has with its clientele is through email and through the websites. And this is a model that should be not just replicated, but the capacity for this kind of engagement with people who are alienated from the systems we assumed would work for the opioid settlement funds. We need to really think outside of the box. So thanks.
Thank you, Tracy. Liz, yep, go for it.
Can you hear me? Yeah. Yeah, my Minnesota's coming out. Thank you for coming. What I wanted to touch on, my innovation, I was told, is the pooling of resources. Now, I'm definitely going to age myself because there was a slide up there about tobacco settlement, and I vividly remember that going into the general fund so that they could take care of a budget deficit. So when this opioid settlement fund came out, I was like a bulldog. I'm just going to tell you, my innovation was pooling the resources. So when you have 5 tiny, tiny counties, they're going to get a pittance. Each little county is going to get nothing, but together we get $2.7 million over 18 years. So we really got 25 commissioners, 5 county administrators, 5 family service directors, got them all in a room and said, how do we pool this money to provide innovative funding? So there's 2 buckets. I'm also a farm girl. There's a feed bucket that's evidence-based programming for 3rd grade, 5th grade, 7th grade, with longitudinal studies being done on 3rd grade, 5th grade, 7th grade. And the second bucket, which I'm in farmland, is CROP, Community's Response to Opioid Program. I figured I'd get people to remember it by talking about crops. And that hands out grants every spring and fall to really look at secondary and tertiary prevention. So that's my innovation, was really wrangling everyone in a room and convincing them that this was a great, great idea. And we've had some really good success.
I love that. And as someone who has interviewed many county officials, sometimes in small places that are like, we're not getting enough on our own, what do we do? That is a great response.
The last thing is really, the counties, commissioners got in a room and they got rid of the county lines. And that's the conversation you have to say is how do we get rid of the county lines? Because the greater good is bigger if we drop the lines. And so $90,000 goes for evidence-based programming. We've done over 1,000 kids in 11 school districts. We travel to every county. We're just crossing the county lines, and the grants are crossing the county lines as well. And the commissioners could see that. I mean, they just could see that it was going to be a bigger bang than getting, we got 14,000 this year. What do we do with 14,000? So they really did see that benefit, but it took a little bit of wrangling to make that happen.
Thank you. Dalton?
Sure. That's a hard one to follow up, but
Not if you're Dalton. It's fine.
In Edgecombe County, so rural eastern North Carolina, we have a county-based EMS system there, and I am a paramedic by trade. So I grew up one of the streets, right? So I've been out doing EMS in the Twin Counties for 13 years, and about 4 years ago, I had no idea what MOUD is. Fast forward, the next year I was hired to manage the post-overdose response team, right? So I took that job, I come off the streets and started to design a program that obviously everybody knows the term, meet people where they need, and then also to fill the gap because we had no harm reduction agency in the area. We had no OTP in our county, so citizens couldn't get methadone in the county. And of 50,000 residents, we had 2 providers that were doing buprenorphine. So early on, we knew there was a lot of gaps when it came to harm reduction as well, but also when it came to treatment. So we did field initiations of buprenorphine through EMS, through the port team, and that was something somewhat new in North Carolina. There were 2 other counties kind of on the western side of the state already doing that had a lot more resources than us. But as we started getting people appointments with treatment, we knew that we didn't want to see them be in withdrawal while they're trying to wait on the appointment. So we started sometimes intra overdose. A lot of there's post overdose response teams is a common term, but a lot of those teams are doing intra overdose response. So starting bupe as soon as somebody wakes up has been a great way to get people into treatment. And really, it's great to give them that, even if they don't want to get into treatment, just to humanize withdrawal and to keep them safe for at least 24 hours. So I think there's a case to be made on the public health side of things. But in North Carolina today, I just checked my numbers a little bit earlier, we have 23 different counties doing EMS bupe. So in North Carolina, there's 100 counties, so about 23%. And over the last 12 months, around those 23 counties, there have been 4,000 individual administrations, and I'm not sure if it was 8 milligrams or 32 milligrams, but that's a lot. But we have much work to do, but we're really excited about that innovation, and everything that we've done has been patient-centered, kind of getting away from those silos of this county's doing this county's doing that. Yes, every community is different, but at the heart of it, it has to be patient-centered, and that's our innovation.
Thanks, Dalton. Melissa?
Great. So I was told to focus on one innovation, and an area I'm going to ask you to hold me on track because I get excited about this work and might go down rabbit holes. I'm like, we're doing bupe in the field as well. But the innovation I'm going to be talking about today is in Wake County. We really wanted to make sure these funds could make a difference. We were not wanting to start from scratch, reinvent the wheel. We have a coalition that's been meeting, coming together for over a decade. And so one of the things we started was asking our partners what they wanted to see in the community. And one of the things that came up was my innovation. I'm looking at Abby because I forgot to mention what that is comprehensive wraparound services. We know that in particular peers and people with lived experience who can walk alongside folks are just critical to navigating systems. Dalton mentioned his county. My county is the opposite. We're about 1.2 million. It's a large county. We're resource rich, but most people don't know how to access services, including myself. It's really confusing. It's hard to know what's out there. And so we've really focused on investing in programs that traditional funding streams like Medicaid don't support as easily. There are limitations such as 15 minutes to visits with peer support. And so we wanted the settlement dollars to really allow folks to do the work they needed to do in the places where they are to support the people that they're working with and walking alongside. And so one of the programs I wanted to highlight is our partner, Rise Collective. They provide reentry support for women released from incarceration. In North Carolina, in the 2 weeks following incarceration, people released from our prisons and jails are 50 times more likely to die of a fatal overdose. And so this is a really critical population for all of us. And so we have been supporting our partners at Rise Collective. It's an organization that is primarily run and led by women with histories of incarceration and substance use. And with the settlement funds, it allowed them to open a center where it is the hub where people can come to access. They're supported through transitional housing. They can access treatment and recovery support. They can connect with peers, do education. And so we're bringing all of those services together in one place and allowing the folks that work there to spend, maybe it's hours, talking to people, asking them about their needs, being really patient-centered, spending the time to take them to visits and go with them to jail or to the doctors. And so really trying to use these funds to allow people to do the work that we know works and that they need to do, and really meet that human side, walk alongside folks in a way that traditional funding streams can't support.
Thanks, Alyssa. And one of the things I love about all the innovations you all heard about and everyone spoke about here is that I think a lot of times when we hear the word innovation, we're sort of attuned to like technology or some sort of new gadget. And it doesn't have to be that, right? Every person here, I think, said people and relationships and human, and that is often the innovation. It's a different way of thinking about it. So thank you all for highlighting that. I will reiterate, now that you all have heard about their innovations, if you have questions for them, scan the QR code and send those in, and I will start asking those as well. But I wanted to start off with some common themes that I heard among you all. So all of you, but I'm going to have Tracy and Alyssa weigh in on this. Both of you talked about kind of centering folks who are most impacted, who have lived experience, and we know historically that has not been the case in public health work, and not just historically, continues today to often not be the case in addiction policy and programs. But both of the innovations you described really center that. Can you talk a little bit about how centering folks who have been marginalized and folks who have lived experience is key to the success of the program? How does the program incorporate those voices, and how does that help?
Okay. And I neglected to say, so Next Distro is getting settlement dollars through New York, but we have something like 16 state partners, and they are also leveraging settlement dollars to participate in this. But I think the key to point out here is how deep the marginalization is, and the fact that we continue to talk about racial equity in the funding, and that's not possible when we have systems that are at their core or embedded inequitable. And despite what this administration may want us or let us talk about, the reality is the reality. So Next is especially critical to people, because it is outside of all of the pathways that have been established. You can start with the war on drugs, but it certainly predates that have been the primary funnels through which money flows. And so to expect that new money will flow through the pathways created by punitive carceral law enforcement responses is purposely delusional. And so the people who are using Next Distro have been hurt by those systems through which funding has traveled, whether it's the addiction treatment system. And again, there are different worlds when we talk about public health and mental hygiene. Shelley, we do know that that's different. Mental hygiene law and public health law in almost every state in this country are different. And that has been the system that has been institutional, carceral, and hurtful, and also very close to mandates and legal forcible actions. So anything that gives people an ability to be autonomous in getting their care without being penalized for it is something that I think people will gather to. Next is also made up of staff with lived and living experience. And that idea of living, yes, that means that people are active in their drug use, and they are able to do this work. So I think that is really the people engine of this, can never be replaced by technology. And the more that we connect people with people, outside of just, we are now recognizing people's humanity. We are now not narrowing people down through this one behavior that they do, which is their drug use, and ignore everything else. We are holistic, we are integrated, and we're listening to people who are doing this. So I think for us, that is the issue. We listen, and we're gathering information from people who are willing to talk to us.
Awesome. And Alyssa, I'll let you take this how you want with the Arise Collective or broader in Wake County. How have you all incorporated lived experience in decisions around settlement money, and how has that contributed to the success?
Thank you. I'm going to talk broadly about our settlement work in Wake County, and I will just say something that's really important is that to do this well, I think it's critical to incorporate lived and living experience throughout the work. In North Carolina, as part of our legal framework, we're required to have a public meeting every year. We were talking about it before we came down, and some counties have their Board of Commissioner meetings as their public meeting, which is great. That is a public meeting, but that is not where people always go. And so we've been really thinking about how do we get feedback in all the places we can get feedback. And so we've had those big community meetings. I'm planning one for June if anyone's in Raleigh. But we also have surveys. We work closely with many organizations that are led by people with lived and living experience. I think that living experience is really critical because the drug supply changes rapidly, the current context we're in changes, so we need to be talking to people who are currently using drugs as well as with lived experience of substance use. And so also I think so key to that is establishing real relationships, and in doing so, making sure that you're listening to folks and showing up and delivering on those promises. When I started in my role, one of the big things I heard was we do not have very much access to naloxone. In Wake County, we're a county of 1.2 million people, and our budget for naloxone was $13,000. And I did the math, and at today's rate, that's about under 600 naloxone kits for intranasal naloxone. And so I see lots of shaking heads, clearly nowhere near enough. And so one of the first things we did was delivered on that promise and showed people we don't want anyone to ration this life-saving medication. And so I think building relationships, establishing ongoing channels for communication, and then really delivering on the promises and if you can't, letting people know why. But I think that's been really powerful. And I'll wrap it up to say that one thing that has been really cool, we have a program called Healing Transitions. They have a rapid responder program, a post-overdose response team, and they actually have it built into the program to do quarterly round robins where they bring folks like me, funders, leadership at the state level to hear directly from participants in their program. And we had one of those round robins a couple months ago for with our state Division of Mental Health Director to hear from the folks receiving mobile opioid treatment program services, so getting their medication for buprenorphine and methadone daily, to tell the Director of Mental Health how that's working and what they need. And so I think we have to go beyond having one big community meeting or putting out a survey in our strategic planning. We need to do it often, establish real relationships, and show up for people.
Thank you. All right, so in addition to incorporating lived experience, the other thing I heard from several of you was kind of working across silos, breaking down, people in their own little areas. So Liz, I want to start with you. You mentioned, getting all these counties to come together, work together, and, ignore the county borders. I imagine that's hard. Like, it's awesome, but it's also lots of places have a hard time doing that. Funding streams are not set up for that. Governance is not set up for that. And the opioid settlement money is coming for a long time. So you might have turnover in who sits on those, in those seats. How have you been able to get people to come together, and how are you thinking about sustaining that?
Thank you. Some of that is relationship based. I have to say that we've had some success in my 5 counties, my five tiny counties, of really bringing down the county lines with success of a nurse family partnership home visiting program that is 30 counties. And so we brought down those county lines, an immunization registry. So we really developed things throughout my career that really brought the county lines down. What I would tell you regarding the county lines, some of the challenges is, like you just said, who will still be there? One of the things that we do in Minnesota, I love when my accent comes out, Minnesota, and and then I'm from North Dakota, is joint powers agreements. And so really a joint powers agreement allows you to really bring a group together. And so I function under a joint powers agreement. And boy, I'll tell you, that's handy, because that joint powers agreement really allows you to be that fiscal host, bring the money to one location. So, the money wasn't siloed out. It really went into one spot. So those joint powers agreements, if you have that ability, a compact, something where you can bring that together, that has really helped us. And then I'm going to be really, it's all about relationships, being truthful, holding yourself to being accountable if you don't know the answer. I mean, all of those things as you're going along are so important, or the county lines come back up. So if you don't keep your word, or if you don't follow through on something, the county lines will want to come back up. And so you really have to really follow through and then report a lot of data. You know, if you've done 1,000 kids that have had evidence-based education, well, I'm not gonna lie to you. Do you think that county actually wants to know how many kids happened at their schools? Yes, they do. They also, though, hear from me how many kids total, you know, because we're really, it's a total. What impact can we make with evidence-based? If you looked at the principles, use evidence to guide spending and invest in our youth. I'm 8% of that budget of the slide. I got 1,000 kids. I need them to not need Dalton's harm reduction. So if I can convince those people in that room to get those county lines down and find a mechanism to do that, which is a compact, a joint powers, some type of agreement, you can really make those things happen. And so the funding will stay with that joint powers agreement, even though the hands of people will change throughout the years.
That's great. So you all have systematized it. Dalton, I imagine the silos that you're working across are, you know, somewhat same in the counties, but also fields, right? You have folks in treatment, folks in emergency response, and you're kind of, you know, asking people to work together and take on some roles that they may not traditionally have had. Talk to us a little bit about how you've made that work and maybe some of the barriers you encountered along the way.
Sure, and that's a great point, because I mean, if anybody in the room has been a paramedic or been a firefighter or something like that, public safety people are very territorial. You're not coming to my city and doing this or whatever. And the interesting thing is that on the west side of our county is a large town, Rocky Mount, that's split between the county lines. Like runs right through the railroad tracks split it. So the old phrase, "You're on the wrong side of the tracks," like that was very, like, you know, it was us, you know. So as we started like building out services for people, it's almost like we had to figure out what relationships that would take and start talking to those people before we needed them, if that makes sense. So like you talked about with harm reduction, well, nobody was at the table there. So we just kind of had to do that on our own. But when it came to treatment, when it came to, you know, referring patients to care, we had to know who those people were first. And then the local hospital system in our area was extremely difficult to work with. They were very not evidence-based at all, and they would kick people out of the ED and just kind of say, don't use drugs, and that happens a lot around the nation. But, you know, now we've got a workflow established with them, and they will literally call us to come to the ED to meet someone in their room because that's the easy button for them, and we're all about it because, you know, it makes sense for us, and we can meet that person right then. So it was all about relationship building and not taking no for an answer. So every time that we dealt with a situation with a patient, I didn't want to deal with that same hurdle for the next patient. So when it came to, you know, doing BUP, you know, that was a thing. When it came to trying to get somebody's blood tested, we would just refer out for that. It was like, why can't we do it? So we started doing that. And then that was always a 2-week turnaround. So we're like, this is not good enough. So now we have point of care hepatitis C testing. So we do that. And then we couldn't get blood work on somebody. So now we have ultrasound. So it's just always, you know, it's blossomed into this beautiful thing 3 years from now. But really, you know, 3 years ago, it was just a guy who was out there with a heart to serve, and, you know, they didn't know much. But he was good at building relationships and, you know, I guess just kind of figured it out. And I think that's important because every community is different. So you have to have people at the table. You got to be creative. And don't take no for an answer because it'll work out eventually.
Can we interrogate two terms that I'm hearing a lot? It may not be for this, but harm reduction, because we might have different definitions, and I bet we do. And then evidence-based. I call it the oppression, the tyranny of evidence-based. Because evidence-based then dismisses evidence-informed, which is people-centered. And again, when we're living in a world of data and metrics that we need to meet, it just comes back. It's just another phrase that I know I like to use that says, you don't throw away anecdotal. If real people are experiencing it, then it's evidence. So again, I think that's a whole other symposium. And again, not to knock the gold standard, double placebo, evidence-based, but there are other metrics that we need to look at to know that we're impacting people.
And I think that comes up a lot when we talk about innovation broadly, right, across all different fields, where to innovate to some degree, you're going to have to try something new that we don't know. But can we build it off of, just a hunch or something that suggests this is going to work? And so I think, in my own reporting, I've come across this a lot where the question is this a good use of settlement money because some people feel it is, or is there some evidence to work off of? And it's not always a clear answer. So I think that's a great point. Well, everyone is doing a great job sending in questions because I already probably have more than I can get to, but I will do my best and keep them coming if you can, and then we can always chat about them afterwards during the reception. But I wanted to start with someone who picked a question that I was already going to ask, so thank you. Great minds and whatnot. They asked basically, how do you all think about sustainability of programs that are started with the opioid settlement funds? The settlement money is sort of front-loaded. For folks who don't know, there's more coming to counties and states in the early years, and the amount gets smaller over time. And then, of course, at a certain point, they will stop flowing. So how are you all thinking about sustaining the work that you've started? I'll open it to a free-for-all, whoever wants to jump in.
Well, I'll cheat and say that I'm retiring in 12 working days, so it's not my problem.
This may be the best answer, but someone try to compete.
It matters. What we've really looked at is how can we eventually look at some billing options with some of our prevention educators that are in the schools. I don't think we have it completely figured out. That's just going to be honest. Minnesota got tobacco settlement funds. We had actually Governor Ventura, if you heard of him, and he literally believed in prevention. And we got to do it for about 4 or 5 years. We all got bought in, and then the next governor came and took it. So, I think it takes Dalton, you hit it. It's building the relationships and the trust and really building credibility with your people, so that they will want to continue it in some way. And I think that's going to take some work for the new successor that is taking my position. That's going to take some real work to make that happen. And I think that we have no guarantee. Let's be honest, you guys, waking up. We have no guarantee of funding, period. I mean, public health has been somewhat rattled back and forth in the last year with funding. And so I think you do your best work, you build your relationships, you try to really make that happen. I do want to touch on my second bucket of funding, because I would be remiss without telling you that is a group of individuals that have lived experience, a high school student, the mental health provider, a hospital, social workers. They're making the decisions on the grants, not me. And it really gets to touch on what you just said. It has nothing to do with evidence. I wanted a second bucket that was no evidence, because you do get tied in with evidence. But I knew that I wouldn't get the money if I didn't have one bucket of evidence. So I appreciate what you said. And so I really wanted to share, because I felt like the person with lived experience in that room needed to tell us what grants came in and what really would work. Not us, but the lived experience, or a high school student saying, do you even know what you're talking about? I mean, that's not even a word we use. So I don't have an answer. I think this was my moment to cheat and say I'm leaving in 12 days and heading into the sunset. But it's going to be relationships at work. Dalton said that, and you just keep grinding. You just keep grinding.
Anyone else want to weigh in on the question of sustainability? Go ahead, Tracy. Go ahead.
Yeah, I mean, Edgecombe County, we've got $5 million to go over 18 years, so we don't have a lot either. I mean, it sounds like a lot, but really at the end of the day, it's not. So I think there's a lot that needs to happen when it comes to like Medicaid reform and like funding EMS or mobile integrated healthcare or community paramedic programs that do that type of post-overdose work, or treatment navigation, or even more funding for peer support, types of programs that have port implications and all that. But I think that needs to happen. But I think in the meantime, we can really try to figure out how to create our own evidence in the meantime while we do have the funds. And then on an administrator side, knowing that I just can't have 20 dudes on this team and pay for them, because we're going to run out of money. And the last thing I want to do is have something around for 3 years just to shut it down. And then everybody had that hope, and things were going well, and then all of a sudden it fell away. But on the flip side of that, I also would caution any county that has not utilized opioid settlement funds, because we see them around North Carolina too, because we do have a problem, and there are services that need to happen now, and what better time than now, right? If we do have some ways to do even small things, we should be doing those, but we should do them in a sustainable way as well. So not just to go all in at the jackpot, but you have to build some things into that. Where should you start? Where should you go? What things already exist? You don't need to duplicate resources. We could talk about this for a long time.
And just to, on Dalton's point, it's not just North Carolina. All over the country, there are places that have not spent the money yet. Tons. I wrote a story about that first, or an article about that first, I think 3 years ago or 2.5 years ago. And then every year I've had someone ask me to write the same story, because there are still lots of counties and cities that are sitting on the money while there is an urgent need. And there are complex reasons for that, which we can discuss, but I think that's a great point, and something that is a national trend as well.
In terms of sustainability, one of the things that I get pushback on, and again to the issue about what do I mean when I say harm reduction? When I say harm reduction, I mean housing, period, point blank, full stop. The fact that we are not providing housing that is so crucial to the kind of health and well-being that we want in people, and what better use of opioid settlement dollars for things that will be around later. I hate that phrase, building the plane while we fly it. That means you're not planning. That means that it's a busted plane. And so I was just reminded the other day of an article that someone I'm a fangirl of, Eric Godora, wrote in the Washington Post when we were in the midst of COVID, and he's like, we respond to everything like an emergency. If people in harm reduction, and I've been doing this for 36 years, we run into the fire to save people, and we don't know how to get out, and we don't get a chance to figure out how the fire got started or how to fireproof ourselves. So I think in many ways, the times that we're in are a chance for us to build capital projects that embody and reflect what we know should be, that do not perpetuate harm in helping people, that don't extract and make people silo themselves to get what they need, and that it's informed by what people say this is what's most important, which is almost always housing. So I'm really a big fan of people using opioid settlement funds for housing or other kinds of durable things that will be here after the settlement money runs out. And I just want to say, this is not, I love lawyers, I'm not one, but letting lawyers develop a strategy for addressing a health emergency, we got what we got. For some of us who are old enough in the room to remember HIV, Ryan White Care, some folks have heard me say this, and I want to retire so bad. So bad. I want to go off into the sunset. I really want to. Ryan White Care and HIV prevention planning from the CDC required government and community concurrence, and the money could not flow unless there was an agreement about what the needs were. We're not done with HIV, and I say that as National Black Harm Reduction Network. We still have a bunch of work to do on the inequities, but did I think I'd live long enough to see something damn near close to a vaccine? That's where we are with HIV. For me, we're still in the 70s in many ways in how we're approaching people who use substances.
Alyssa, I have a different question for you, if you don't mind. Just there was one that came in where someone was talking about using opioid settlement money for prevention, and is it possible or not? There's some confusion around that, and some of us were chatting about this before we came on here. So I was wondering if you could start and talk a little bit about kind of how you're allowed to spend the money in North Carolina, and how prevention fits into that, or where it fits in, and then I'll ask others to weigh in as well.
Thank you. I do have thoughts on sustainability. So if you want to hear my thoughts, we can talk at the reception. But prevention is a little bit my Achilles heel, because in North Carolina, we actually cannot directly use settlement funds for prevention. Our continuum of care starts at early intervention. And I'm not going to go down the weeds in explaining all these details, but we have two options of lists we can choose from. One being a short list of high impact, evidence-based and evidence-informed. They're not all evidence-based. I think that's a really important point. Strategies that we can choose from, and most counties are using that list, and it doesn't include prevention, because there was a lot of fear from lawyers and others in North Carolina that these funds would just go to programs like DARE. And, before I was in my role, I was all on board for that approach, and realizing our community wants prevention, they want education, and not being able to directly use these funds for that has been challenging, because I don't want to hear this need from our community and not be able to address it. So we thankfully also are receiving other settlement funds like McKinsey and Company, which follows the Exhibit E list. For most other states, that's your guiding framework, and that has a longer list that includes prevention. And so in North Carolina, it's complicated, but in other states, there are a lot more options. But like any of the settlement funds, it requires a lot of creativity regardless of the context.
Thank you.
Okay?
Yeah, no, that was great. And Alyssa simplified a very complex process in North Carolina, so kudos to her on that. But the one point I wanted to add is that what she already said, it's different in every state. So your state may have more allowable uses that fall under the prevention bucket. Your state may have passed additional laws. Your county may have passed additional restrictions. So it's one thing with the opioid settlement money is that it's different in every place. There are some overarching guidelines for everyone, but it really is locality by locality what you're allowed to do with it and how you can navigate that. Did anyone else want to weigh in on prevention spending, though?
Again, I'm sorry. I talk about this stuff so much. I cannot wait to stop talking about opioid settlement funds. What do we mean by prevention? Harm reduction is pathway to harm elimination. That's prevention. These are weird. My 25-year-old always says, "Mom, you're so weird." These are weird distinctions that we need to be able to push back on. We have a lot of allowable uses, but we don't have a very robust list of things we shouldn't be spending settlement dollars on. And that to me is a little obscene, that you can't use settlement dollars for prevention, because clearly the belief is prevention is abstinence, treatment is abstinence, and we know better, right? Like, we know better, so.
Yeah, I think this.
I am such a public health nerd, so bear with me. There are 3 levels to prevention. There's primary prevention, secondary prevention, and tertiary prevention. And we are doing, look at the grid. We are doing tertiary prevention, which could be housing. It can be harm reduction. Where we fall down is in primary prevention. We just plain fall down, and we are really hurting our young people, our little ones. The little ones need the education and the support and the guidance to help them make decisions for the secondary and tertiary prevention that you all need to do. We all need to be doing it. Everybody needs to be doing it. We have 3 grants that are going into our incarcerated jails. That's tertiary prevention. They're struggling there. They need grant dollars to be there. But boy, I got that 3rd grader, and I am hoping that they're never going to go there. So
how do you gauge that? That's part of the struggle for
Have
primary prevention. How do we measure? And the fact that you're doing longitudinal is so smart, but most people think prevention primary is there.
No, but primary prevention, you just nailed it with the primary prevention, is it is hard to measure. That's why people don't want to fund it, is because it's hard to measure. And then I go back to your line that I want to use is you better have good anecdotal. You could have the data, but then put the story with it. Let me show you the third grader that went home at parent-teachers conferences and literally said, my prefrontal cortex, I know how to regulate it now. And the parents like, what the, I won't swear, what the blankety blank. And the mom said, they're talking about how to manage their emotions with their prefrontal cortex. That's take the anecdotal story with primary prevention and you will sell it. But you have to have both. When we cut ourselves off at the knees, what the heck am I going to do in 12 days, you guys? I'm like, just, woo, get me going. Anyway, I just want to make sure you hear there's 3 levels of prevention. I'm probably speaking to the choir. But we cannot forget about primary prevention. We just can't. Sorry.
Stay, don't leave us.
No, I'm done.
Dalton, I have a specific question that came in for you. How is North Carolina or Edgecombe County, or both, tracking the number of individuals who receive EMS-delivered BUP? Was this a partnership with medical systems or to create the care navigation, or was it housed within EMS community paramedic programs? I guess those are 2 questions, sorry.
Yeah, so I would say that most counties that are performing EMS BUP, probably about 3/4 of those are through community paramedic programs. There are some counties like Wake, I believe they have it on the ambulance, so it's a little bit different. But I mentioned earlier about some of the statistics and the dosing that we've seen over the last 12 months. That is tracked. We have a data team at the North Carolina Office of EMS, and when you submit data, you have to have all these NEMSIS validations and such, which, everything's a data point now. So basically they just pulled out BUP, and it doesn't matter if it was a ESO platform, which is very common for PCR systems in EMS, or if it was image trends, or if it was EMS charts. It was that NEMSIS data point of buprenorphine administration. That was what was pulled out over the last 12 months.
And they also asked this, which I think is a great question. How can a member of the public find out which counties are offering EMS BUP?
That's a harder question because I don't have a great answer for them. But what I would say is contact the North Carolina office, or contact your office of EMS and ask them. Or your county, but each county is different because it may be county-based EMS, it may be, like in DC Fire, it could be AMR, and each one of those agencies may have a different protocol list. And it takes a really progressive EMS system to deliver BUP, and not everybody is bought in yet. We have some early adapters, but then we have some folks that, well, we're not doing it that way because 20 years ago we didn't do it that way either. We have some of that too. So I think slowly we're heading in the right direction, but I think it's so different county to county, it's hard to say.
Wonderful. An interesting question that came in for all of you, I think anyone who wants to answer it. Have you experienced pressure to allocate funds in ways that do not align with opioid remediation? And one thing that came to my mind that I know I've reported on a little bit is there has been companies that make products are aware that this money is flowing to counties and cities and states, and there's a flood of marketing to try to get the money for their product. So that doesn't have to be the angle that you all talk about, but that came to mind. I'm curious if you all have felt pressure to use it in ways that didn't feel like they matched the purpose.
Is if 4 milligrams of naloxone is good, then 8 milligrams is not gooder, if that makes sense. And I'm sure that some of you all know which company I'm talking about. And I did turn them into the FDA, and there have been some things that have happened from that. But that, yes, I mean, the marketing is real, and they're coming after you. Anybody that does opioid settlement, program management, they're coming after you with their hand out. So we've had the same subrecipient come up to us, like, give us $3,000 or $300,000. We've had the pharmaceutical companies. We've seen companies try to bolster EMS NARC boxes where we keep controlled substances. That's not going to help somebody with an addiction, right? That's just there to, like you say, take some of the budget strain off of the EMS budget. Like, it's not going to benefit patients. So I've seen that so much. Does anybody else have something?
Up until recently, I was on our state settlement board. And that's another conversation if you want to have it with me. But I swear, on LinkedIn, people are hitting me up like I'm carrying around settlement dollars in my pocket. And they're disgusting. And they almost always are hitting me up for innovative strategies to reach underserved Black communities. And it's disgusting and it's gross. But if we disrupt this idea that people cannot gain sustained health and wellness from addiction treatment and other interventions, then we're going to remain very vulnerable to the for-profit mandate. Because some would argue that is what is driving this, is that we don't get people well enough to not have to come back.
Yeah, Melissa.
Careful, because I know this is being recorded, so we can chat more later about the Dalton and I get a lot of the same emails. But a couple things I just wanted to say. I think someone mentioned earlier that the importance of systemizing and building process, and I know it's not the sexiest of topics, but I think really building guardrails is important, because I might retire from this role. I don't know. I still have a while left in my career, but who knows? I could win the lottery, or my husband could win Jeopardy or something, and I might not be here. And I want to have these systems in place to make sure the funds are going to where we know they need to go. And so I think that's a really important part as you're building, if you're in a role like this, to have competitive processes, to build systems to be transparent, to have built-in frameworks for community engagement, because that will hopefully last after people change roles. And then I had another point, but I was thinking about my husband winning Jeopardy. So my, what was the thought? But yeah, I think just the systemization is really important. Oh, and then I think it's really critical thinking about sustainability is to tell the stories of what you're doing with settlement funds. And that's actually how I am on this panel. I think Abby saw the video that we put out, but we're doing a storytelling project where we're having our programs that are funded tell the story of what they're doing with the funds. Because I think, as you've reported on a lot, Aneri, there's just no clear there is now a clear place, but everyone's doing different things, and it's hard to tell what was happening. And I think just having people telling their story about how the settlement funds have impacted them, it's both that transparency piece, but also it's a way for sustainability. I'm hoping maybe some other funders in our community will see these videos and say, oh, I want to support this work beyond the settlement funds. And so I think, how can you take that data, but really that qualitative, anecdotal, individual story is so important.
Can I follow up on the funder piece?
I just want to quickly say, masterfully done, Alyssa, to work in the answer to the question that I didn't give you.
The funders that I hope are watching as well, I hope they understand that while settlement dollars are bountiful now, to the extent that they flow through government entities, funders must fund us to get the money out. There has to be an inside-outside strategy. Some of us have worked in government, for me very briefly, but what I saw plainly is that the external advice is critical for the money to flow. It just has to happen. So there was a lot of running around, fear, federal dollars disappearing for life-saving efforts. Harm reduction that I grew up with never relied on any government money. And it happened whether there was money or not, because it was people-driven. But to also understand that the harm reduction that we understand and know about now was built by philanthropic dollars supporting organizing and advocacy work. And we don't like to talk about lobbying, but it's not really lobbying, except to the extent that, it's legally defined. It's ensuring that the money will flow, and it won't happen just because the money is there.
All right, one final question that I'm hoping all of you can weigh in on, and hopefully this will also set up what Regina is going to talk to everyone about. With federal funding squeezes, have you seen jurisdictions dipping into settlement money to make up for funding gaps? Do you anticipate this problem will get worse if overdose death outcomes continue to improve, as government may feel more at ease about siphoning off money? Who wants to start?
Yes. Yes. And I think that's why that building systems and structures are so important, because in the past 2.5 years that I've been in this role, I'm only getting more and more emails and requests, and they're coming because of funding cuts. And I think one thing that has been critical, I mentioned that we have our coalition. We're really trying to make sure that our community is guiding how we use the funds. We've been going through a strategic planning process where we're really solidifying the values and the goals and what we want these settlement dollars to do to prevent that from happening. But it's only going to get worse, I think.
Yes. I think the luxury of building those relationships is I've been really gifted to have commissioners that believe in the work we're doing. What I would tell you is having that joint powers agreement in place, so you have a fiscal host and the money's put away, it's dedicated, it's put away, has been crucial. And I'm losing my train of thought of where I was going with this.
Just about federal funding
Going
squeezes
away.
And how using this, if you're being asked to use this too.
Thank you, bear with me. See, this is why I'm retiring. So what we have is bylaws and a contract in place. And so by creating bylaws and creating membership, having those documents, and so it's what I wanted to just reiterate what Alyssa said, and I'll use the word, processes aren't sexy. I mean, that's not fun work. Believe me, sitting around doing bylaws and on the 9th revision of a bylaw, to have everyone sign, it's like that is the most boring part of it. But once they're in place, the ability to have someone come in and say they're going to take your funding, yep, we're going to tap into that funding. We're going to tap into that funding. It's like, that funding's pretty locked up. It's dedicated over here. It's locked in on contracts. It's got bylaws. There's things in place. So it makes it incredibly more difficult. Now, again, in all seriousness, I'm leaving. Does someone change their mind 5 years from now? Someone wants to change the bylaws? Who knows? You try to set the process in place and hope that it works, but we're at the whim of a lot of people grabbing at things from us.
I'll just say no, because we passed a law. We got a law passed with the AG's support that made it very difficult to do what we call sweep into general fund. Now, it's prospective. It's not retrospective. So of all of the various settlements, it names the big ones, but there are many. So moving forward, we'll be able to protect that money better with this law, but laws can be amended.
Dalton?
Yeah, I mean, I think I'll go. I say yes and no. I think we've done a good job in North Carolina to really earmark that funds as blood money, which is what it is. I think a lot of the people that we meet with understand that. So as long as we stay employed, I think we're in a good headspace. But with that being said, I think there can be some opioid settlement turnover that occurs, and that whole county is flipped upside down. And now they're grabbing straws, and who knows what might happen with the money. We're 3 years in. We have not got an audit yet. To me, that was something I was expecting maybe 2 years in. So I think maybe when an audit occurs, there'll be some eyebrows that go up that kind of is like, you've seen some of the stuff that people have bought, and it's like, I don't know about that. You see the track and field complexes, you see the tasers, the robots, the drones that drop Narcan. You're just kind of like, I don't know about all this stuff. So I think it could go both ways for sure.
Yeah, and I think that's a great point. A lot of folks here talked about laws and processes that are in place, but there's also the question of enforcement. A lot of times, Abby, when she was up here, mentioned the opioid settlement tracking project we do. There are places that require that counties and cities report out how they use the money, which is a great first step. So then if they're buying the robots and the guns and whatever else. But sometimes I think we on the project team wonder if we are the only ones reading those reports, because it's that next step of you read something, it raises a question, what happens? And I think that's something we're still monitoring. I think, like you said, Dalton, we're all going to see what comes of that. So there are still like 20 questions on here. You all did a great job. You can have my job next time. But that means there'll be a lot to discuss during the reception. But for now, please join me in thanking the panel.
Thank you, panelists. My name is Sachini Vandara, and I am an assistant professor with our Johns Hopkins Center for Mental Health and Addiction Policy. I have the good fortune of introducing you all to Professor Regina LaBelle. Professor LaBelle is the director of the Center for Addiction Policy at the O'Neill Institute for National and Global Health Law at Georgetown University. She has a long history of public service. She was appointed the acting director of the White House Office of National Drug Control Policy under the Biden administration. She served as chief of staff of this office under the Obama administration. And today we have the good fortune of having her here to provide some reflections on the wonderful panel that we just heard, and also to put this discussion in the context of the broader federal landscape that we are all living in. So please join me in welcoming Professor LaBelle.
Thanks so much. I know that you want to get to those 20 questions that you all have, so I won't take too long. Thanks so much to the panelists for that great discussion, and also obviously to Johns Hopkins, first of all, for allowing us to use this incredible venue, and for welcoming so many folks here. I am a professor at Georgetown, where I teach the Master of Science in Addiction Policy and Practice program, and 3 of my students are here. They're graduating in June. If anyone needs to hire any of them, I will introduce you to them. So a couple thoughts that I had, kind of thematic from the discussion, that I wanted to bring up, and then I'll talk a little bit about the federal issues and how that's kind of impacting local governments. I have learned this the hard way. I'm an attorney. Storytelling to me, I know it's important for litigators. I wasn't a litigator. Stories really matter. Data and science obviously matter, but the people and the storytelling matters even more, and particularly to policymakers who have to make these decisions. And then the other thing, and I know this I'm only really getting to the top level of what was discussed, don't travel down the same well-trod roads. You get ruts and you don't move forward. And I think that was really the theme. I was so struck by, how can we think differently so we're not kind of doing the same thing over and over again and expecting a different result and leaving out a whole lot of people. And that's why it's also really good to have new people in this, to bring along new voices. And so I'll talk about these 3 things, but first, I don't know about you, if you work on this issue, you may hear this all the time, I know I do, that it's a niche issue, that substance use disorder is a niche issue. So I'm going to tell you why it's not a niche issue, why it's a fundamental public health issue of our day. So first of all, according to the National Survey on Drug Use and Health, almost 50 million people in the United States have a substance use disorder. Now, they don't all have chronic conditions, but almost 50 million have a substance use disorder. 42% of Americans know someone who died of an overdose. This is not a niche. More than 300,000 children have lost a parent to an overdose in a 10-year period. That's a 10-year period. That's not, what's happened 2022 to today, or even before 2011. And we see these children in our schools. We're seeing them in our foster care system. We're seeing them raised by grandparents. The bow wave of this issue is going to be with us for a long time. 12% of children live in households with at least one parent with an untreated substance use disorder. And finally, if that wasn't persuasive enough, the NIH estimates that the economic cost of substance use disorder is more than $700 billion a year. And that's from the National Institutes of Health. So it's far from a niche issue. I'm not going to go over this. I want to use this metaphor about dominoes, because I think the cuts that we're going to see that's happening this year and we're going to see next year on Medicaid are going to cause a domino effect. So first of all, we have Medicaid work requirements which will begin next year. We don't know, now there is an exception for people with substance use disorder. We don't know what that's going to look like, and we won't know what that looks like until June of this year when HHS issues some rules around that. Those aren't rules we get to comment on, they're just rules that go out to the states. States are preparing for that now. And if, we hear all the time the famous Justice Brandeis statement that states are the laboratory of democracy, well, we've had this work requirement experiment before, and it didn't end well. We know that in Arkansas, because I do think that if I'm going to give people the benefit of the doubt, I do believe that there are people who wanted to help folks get more at work while they're on Medicaid. And the fact is the majority of people on Medicaid do work, or they have another exception. But what happened in Arkansas is, as Tracy said, which is so important, I worked in government, I worked in local government. There are a lot of unfunded mandates. People don't like to fund government to do more. And one of the problems that happened in Arkansas, it wasn't that people were not working, it's that they may not have known about the work requirement. The computer systems, I just read this, the computer systems closed off at a certain time. How does that happen? So it was the red tape and the bureaucracy, some of which was probably due to underfunding or not thinking about it. States are preparing for this now. And individuals may not, we know this because we work in this, many of us live in DC, but a lot of people are not aware of this. They're busy living their lives. So once this happens, and the estimates are that 1.6 million people with substance use disorder will lose Medicaid coverage. That's domino number one. Domino number two is people who are uninsured and have a substance use disorder get their services paid for by the SAMHSA block grant. The SAMHSA block grant has been level funded for a number of years. You're welcome, Rob Morrison. Level funded for at least a decade, but he knows all the data. And you are unable to do more creative things when the SAMHSA block grant has to continue to pay for people who are uninsured. As we increase the number of people who are uninsured, that becomes a safety net. That's domino number two that falls, that block grant. So all the money that the block grant had been spending on other things are no longer going to be able to do it because they have to provide for people who are uninsured. And that brings us to domino number three, which is when fiscal shortfalls meet these abatement funds. And there are guardrails, but as we've seen, there's also a lot of creative lawyers out there who can look at creative ways. Well, we'll just, as happened in New York, we'll just take the interest. That doesn't really count. Or we'll pay for this certain group of individuals. So the issue, it's only going to get more serious as the abatement funds continue to flow and as these dominoes fall. The other concern I have about the abatement funds slowing or see people seeing, well, we don't need this anymore, is kind of just forgetting about what got us here. I mean, it's really important that we remember what got us here. Every once in a while, watch the Purdue depositions, and you remember why. Those statements of Richard Sackler, those statements of the individuals who really are responsible, it wasn't just Purdue, who really are responsible for what brought us to this today. And this is, again, what Tracy said, and also I need to give a shout out to my colleague Shelley Weissman, because she says this all the time. Where do we want to be in 20 years? At the end of this abatement funds, what's our vision? What do we want? Because right now we're rescuing people, and we need to rescue people. But what happens when we get beyond that, just rescuing people? What's it going to look like when we have a system that serves people and ensures that science and compassion are the operating system for our national response? That we don't have to just keep spending money in the same old ways. We can think about what happens in 20 years, 18 years, 17 years. What do we want it to be? What do we want it to look like? And so I thank you very much. I know that there are refreshments in the back that you, and I know that you're looking forward to asking more questions. Thanks.
Thank you so much, and thank you to all of our speakers. I won't hold you anymore. There's snacks and drinks in the back. Please join us for a reception, meet somebody new, and thanks so much for coming. One more round of applause for everyone. Thank you.